This is the Owens Recovery Science Podcast, hosted by physical therapist Johnny Owens.
Hey there, welcome back to another Owens Recovery Science Podcast. I'm Johnny Owens, your host today. I'm back on with Kyle Kimbrell, and then we have one of our great friends. We've been working with blood flow restriction for a long time out in Los Angeles, Heather Milligan, who runs or is founder, owner of Elite Ortho Sport Physical Therapy in Los Angeles. She has an amazing clinic. I've been lucky enough to be there at her old clinic, and then I've been at her new swanky, fancy clinic as well. She has an amazing staff that we're friends with. We've done courses out there, and she's kind of one of these clinical experts in blood flow restriction because she's just doing it so much and has been doing it for so long. So we really want to get her input of how she implemented it, how she works with, Kyle, I know we just had this on an inner circle, someone saying, my doctor still doesn't want me to do it. How do I talk to a doctor? And Heather really has these amazing relationships and has been able to do it on post-surgical as well as non-surgical people with a lot of success. So, as I said, she's the founder and owner of Elite Ortho Sport Physical Therapy in Los Angeles, California. She went to Texas Women's University in Dallas, Texas, and has also received her master's in business administration, which is a good thing to have when you own a rocking clinic like she does, from UNLV. She's board certified specialist in orthopedics and board certified specialist in sports, and also maintains a certificate in orthopedic manual therapy. So she's kind of checked all the outpatient orthopedic specialties that you would need. So Heather, thanks for coming on during this coronavirus quarantine time.
Yeah, thanks for having me.
Cool. So kind of want to get your backstory first. So tell us a little bit of, how you started in physical therapy, where you started, and why you decided to get into private practice, and go from there.
Yeah, well, I swore up and down I never wanted to be in private practice. And I think, back in the day when you work as a rehab tech, I was fortunate to work with a family friend of ours that he had a great outpatient PT practice. He actually had a few offices in Denver, Colorado. And I went to work with him when he went to work, and I went home when he went home. So I saw pretty early on what the hours are like for a private practice clinician, but I was fortunate, he's super passionate, really good therapist. And so I thought, no way, man, I don't know that I want to do this. So when I came out of school, I went to work for, big national corporate chain, did all of that. And eventually, I landed out in California, and I think was fortunate at that point in my career to get to start to work with the guys at Curl and Job, and it was sort of inspired, I guess, re-inspired, so to speak. I think anytime you get the opportunity to work with the best in any field, I think it's really motivating. And so that was sort of like how I ended up about this way. And then ultimately, I think, when dealing with the kind of population that I work with, it was more and more difficult to sort of operate that in a large corporate environment, and ultimately started my own practice against what my whole plan was. And so now I've got this practice, and it's crazy. And we have 15 therapists outside of myself, and feel very, very fortunate, spoiled that we have, great patients, great therapists, and great physicians that we get to work with.
And you see the everyday kind of orthopedic patient. And then also, if you ever are at Heather's place, there's usually some really elite athletes as well. So you kind of see the best of the best from people in their professions, from pro athletes to probably freaking movie stars and everything else out there. So you're kind of like one of these go-to practices in LA. When did you start Elite Ortho?
Started in 2013.
Okay.
So it's gone by fast.
Yeah, it's crazy, right?
Yeah.
You're going to be hitting your 10-year here pretty soon.
Oh my gosh. Yeah. Yeah.
Once you hit that 10-year, it means you make it. You don't have to do anything anymore. right?
Yeah, right.
Hands off at that point. No,
Oh,
no
man.
more worries.
Yeah,
Hardly,
like I said,
hardly,
when I did
especially when you're a control freak.
yeah,
Not gonna happen.
especially right now during this time, we're all like
For sure.
questioning where we're going to be going. Yeah, and like I
Yeah.
said, when I did my first course, it was at a facility that was still a nice size facility, and you outgrew that one and had to move into a larger space in LA.
Yeah. So we when was that course? That course was probably
2017
It was
17 or 16. Yeah.
I think it was 2017 because I took your course
It was in March
in
2017.
2016.
Yep.
And so then the following spring after I went was when I had you host the course at our office.
Yeah.
And when I first started hearing about blood flow restriction, it was through a couple of our patients, and this was back 5 years ago. And we happened to have like a couple, pro athlete in football, one in baseball, that had left the facility to go see their teams and then came back. And I'm hearing these like crazy stories. If you can imagine how this athlete is trying to describe to me, they're putting this thing on my leg and like my leg's turning purple. And I'm like, what is going on here? Right. And so I hear about this a little, like, again, a few times. I'm like, okay, I don't know what they're talking about. So we got to look into it. And finally, by the time then your course rolled around there at Kyle's facility, I was like, I've had enough. That's it. I'm like, this just sounds wacky. And so I'm going to go see what this is all about. And I called Dr. Elatrash. I said, that's it. I'm going to this course. I'll find out what this is all about and I'll let you know.
Yeah.
And so I signed up for the course, and I remember sitting there, and it's like 2 hours into the course, and I'm like, oh my God, this is like the real deal. This is crazy. This is so cool. And I was so amped and so jazzed. And I was like, this is legit. And so it was sold. I called Dr. Elatrash. I was like, this is really cool. I said, this is a game changer. And I remember I bought a unit, and I think I used the unit like a week in the clinic, and I ordered the second one because immediately, I remember the first case that I used it on, and I was like, oh yeah, no, we got to be on bilateral. This one just isn't enough. And so that was sort of how I initially, and I tell everybody, I was a complete doubter at the beginning. Total doubter. But I was like, I'm not going to be a doubter until I really legit understand what it is that I'm doubting. And then it was like, this makes complete sense. And then obviously, as you use it in the facility and you see what the results are. Yeah.
I think that's what's funny about blood flow restriction. It is the thing that, it's becoming more common now. So most people have a little bit of a clue. But in those early days, like back when you were looking at it, over a decade ago, when I was trying to describe it, you describe it to people and they're just like, what the hell are you talking about, dude? Yeah. But then it seems like if you get about like, they're like, what's your elevator pitch? And you try and describe this in like a minute or 2 minutes, and people are like, barbecue chicken, you're on crack. Like, what are you talking about?
Yeah, exactly.
And I'm always like, can you give me like 30 minutes and I'll really tell you. And then it's usually like, you see people in the courses like, oh my God.
Yeah. You start talking pathways, and therapists are like, oh my God, especially outpatients. They're like, not neuro pathways, right? Because I didn't want to go into neuro, right? I forgot all of that.
We don't go there. Yeah. We stick to physiology. Yeah. And just to put it out there, we got a lot of international listeners and others. So Curlin Jobe is probably one of the most elite orthopedic surgical centers in our country. We've got these kind of like mega centers. It's Curlin Jobe, Stedman Philippon in Vail, Rush in Chicago, HSS in New York, and KJ kind of just controls all of that West Coast. And Dr. Elatrash is the maven, the kind of the main guy. He's like team physician for freaking, I think, every pro team west of the Mississippi, it seems like. And so, that's the thing too, like Elatrash was one of those guys that he seemed to really buy into it. Arthrex had this like kind of secret society meeting one time in Florida with all the Arthrex, like big dog physicians, and EleTROSH invited me out just to make sure that all the Arthrex physicians knew about this. So it's pretty cool to have that kind of like, top cover support for that. So
definitely. I think those guys too, I think part of what, I think they do a good job of recognizing sort of the relationship that you need to have with the physical therapy community in order to make their work look even better than it is. Yeah. And so I think that's sort of, we've been fortunate to have that relationship where they respect and ask for the input from the physical therapy community, especially on things like this, and work together, and on the research side of things to say, okay, how do we want to implement this? Yeah. Especially in those early days, as we were seeing some really good results, but it's a little scary if all of a sudden, you're throwing this out to the world and nobody knows really what to do with it.
Right. Yeah, no, and it's almost like a, bad pun, but it's almost like a virus spread. When the KJ guys are on board and they're telling people at conferences, we start blood flow restriction, after surgeries, that really helps kind of spread the message throughout the whole orthopedic community. And I think that's what EleTROSH and Limpavasti and all those guys have really done. Kyle and I talked this week with Adam Cady, who's one of the PAs over there at Curlin Job. And, he kind of sends out all the referrals, and he was saying, they're really not sending referrals out for their post-surgical patients if you're not doing blood flow restriction. In particular, if you haven't been certified to do it right, and you're not using proper equipment, they really want to make sure people are using like a Delphi system or a similar something that's that level. So, and that's obviously the way you probably help kind of steer that by educating them.
Yeah. Well, I think, early on when you see sort of how this all evolved, and when you're starting from a place where you hear about it and you're like, this is crazy. I can't imagine like how this works, to, wow, this really does work. But you're coming at it from a scientific place, which is, what are the variables that I can control? And there's no device out there that you can control those variables, unlike this system. And when you're dealing with surgeons that understand what a tourniquet is, right, and what that is because they use it in the OR, and that now that's been modified to use in the clinic, I think that's been helpful. Because I think they understand sort of the dangers that can come along with that. If you have somebody who's just, no offense, like the Looney Tune crazy guys down there at Gold's Gym that are strapping stuff up on the, you go out there and you're like, oh my God.
Yeah. Right? Yeah. There's one of the surgeons at a conference, mentioned that to me too, that he's very cognizant of the liability when he's writing or prescribing blood flow restriction. And he sends a patient there, and then he's like, I don't like to know that I just gave up all control of what that person could be doing, because I'm sending the person there, and they're going to come after me if that person gets injured. So I think that liability is something we have to really think about. And I know the surgeons think about it. It's probably why we have so many that work with us, because it's from the safety side. So
for sure,
from a clinical standpoint, you're implementing it, throughout your practice. Can you just kind of give us an idea of what diagnoses you're using it with, kind of when you started, post-surgical, things like that?
Yeah, I think if I go back to, so we were back in 2016, after I took the course, we started using it. And, I distinctly remember like a handful of those cases that we used it on really early on. And my practice in general has a very high post-surgical population. You're probably running 50% of my practice is post-surgical stuff. So you see a lot. And that very first case that I used was a professional basketball player that had the percutaneous tenotomy under ultrasound, and had basically a quad tendon debridement, had a lot of necrotic tissue calcifications, and they did that procedure and did a BMAC injection, drilled into the superior part of the patella to kind of stimulate some more growth factors. And we were seeing quite a few of those type procedures at the time, and they were challenging because they would do that procedure and they'd put the patient in a leg immobilizer for 4 weeks, partial weight bearing, and then you'd have to sort of rehab your way along. And you were looking at, without blood flow restriction, a 12-week sort of progression.
Yeah. Yeah.
So this particular patient, we do that, and he like had a phenomenal, we were able to use it almost right out of the gate. And it really helped, number one, kind of take the edge off of sort of that endorphin level that an athlete is looking for, that they have that sense of like, oh my God, did I do something today?
Yeah.
And he did really, really well with it. I think we were fortunate to see, with the physician at that time, they did serial ultrasounds at every follow-up visit. And I remember that it was the 10-week mark or so, and patient was doing well, girth, quad girth is good, all of that stuff. And the physician does the ultrasound and was like, oh my God, like I've never seen this. And he was talking about, he saw like a blood vessel into the tendon, like the healing process. And this is one of those guys that just, he's like as flat energy level as ever can be. And he was like amped up. And
nice.
So that was cool.
And he presented that, I know who you're talking about, and he presented that case at that same Arthritic Society meeting.
Yeah.
And I know the player you're talking about, and I know the team he's with, and he's like a BFR addict now.
Totally.
Yeah.
And it's an interesting, I think, when you talk about longer term, and he's totally bought in. And I know there's the debate in the tendon world about, oh my God, you can't just do BFR only. And I agree, you don't just do BFR only.
Right.
But I also think he's, this has been a case where I've watched him over the last, 4 years, and he does a mix of BFR with regular body weight training.
Right.
And I think that's worked out really well for him. The other, shortly after that case, I think within a month of that case, we had a NHL player that we had fresh out of an Achilles tendon repair. And that particular case, I went back and I looked at it. He was playing in an NHL game by 6 months.
Wow. That's awesome.
And, and these were the kinds, so this was sort of we were fortunate, right? Because these are some of our first experiences using it.
Right.
And, we had like, you're applying it to some of the best population that you can imagine, right?
Yeah.
A professional athlete. So you're sort of starting with the best, physical specimen that you can.
Gene pool is pretty good. Yeah.
Yeah. But it was at the same time, then we had she just turned 16 years old, ACL reconstruction, patellar tendon. And it was pretty popular in our market that as a clearance milestone to return to sport, they were testing these guys in a motion analysis lab, I think down there at Motion Performance Institute, where you guys have done a course recently. Yeah. And they would do isokinetic testing and all of these things. So these 16-year-old girls with ACL tears are probably some of the toughest to rehab to try to get their quad back.
Yep.
And so we're sort of familiar with looking at the results of these first tests that, return to sport testing that we would do. So we had this girl, she had been using BFR from, again, immediately post-op. And she goes in there for her 5-month, first shot at this to sort of baseline, see where we're at. And we get the results back, and she's got a 2% quad deficit at 5 months.
Wow.
And I've been doing this a long time, and have seen some professional athletes take that test that were like 20-something% deficit. And so I thought, okay, well, is she smart enough to fake the test? I don't know, and I don't think so. But even even her glute strength was only a 10% deficit at that point, which, historically we just hadn't seen that kind of stuff. So
we know those guys over there that do the test, they're pretty hardcore. And what's cool about that is it's not you testing. So you had this, other outside source that is blinded to the treatment, which makes it more valid, which is really cool.
Yeah. So
I think, how did that return to sport decision making go from that point, Heather? I mean, how did the surgeon respond? How did things move forward? Because certainly, I mean, we know current best evidence is like you got to give it at least 9 months.
Yeah, and so those things we sent her for the test, thinking like, okay, let's just see where we're at. It's almost like we're definitely not sending them back at that point, but it's like, let's see where we're at, and you use it sort of as a motivator as well. And so that was great to see. And it told us, okay, we're on the right track from a strength perspective. And we, said, well, we definitely need to keep doing that. Mm-hmm. And then also, motion analysis wise, she did well, but we ultimately didn't release her for probably, another 4 or 5 months after that, because there wasn't a need to. She was young, but she was performing well. But, especially with those younger ones, we like to protect them. But I think it definitely got the surgeon's attention. It got our attention, because you're impressed when you see a professional athlete have an outcome like they have. But when you see a 16-year-old girl who's, a volleyball girl, so she's already like probably 5'10", legs up to her ears kind of a thing, and you're
very little exercise history historically, resistance training in the gym, so you're kind of that first touch point for this person actually putting forth effort with resistance exercise a lot of times in that population, and they've got to work really hard to get that muscle back. For sure. And I think, when I looked at it, we see a lot of patients, and as a whole, if I were to look at how many patient interactions with BFR have we had since we started using it, and we're probably pretty close to 50,000. And so with that number, you start to see you pick up on little pearls and things. And I think, having been to several of the courses and hosted them, and I think one of the big things I tell like my students that come through or new therapists that join is what I see a lot of times is people, they sort of vegetabilize and go brain dead when it comes to their clinical reasoning. And they think, oh, well, I have BFR, and so that's just going to fix my patient. And it's a disservice to the patient, but it also doesn't, you're not utilizing BFR for what it could do, right? This is an added thing on top of the right clinical decision making. What's your normal exercise progression? And this is allowing you to do more. And so I think that was the first thing that I would tell them. And then the second thing is that most often I find that their therapists either aren't prescribing it enough. They're like, okay, I'm going to throw this cuff on them for one exercise. And they're sort of like half-ass watching them do an exercise. And it's just not enough. It's not enough volume, and it's not enough load. Mm-hmm. Mm-hmm. And I know you guys have talked about this in the past. This is a little bit of a religious experience when you first start doing BFR, right? And it's not exactly comfortable. Yeah. And sometimes you got to work your patient into that. But, we try as much as we can. I want you to barely be able to finish the set. Yes. At the end, I want you to be wiped out. And if you're not wiped out, I don't want you to worry about not being able to finish, because I'm either going to drop the weight down or I'm going to help you. I'd rather be in that scenario than for you to finish and say, I got gas in the tank. And that's a really hard thing for people to push themselves to. Right. But that's a requirement in my mind on the clinicians that are applying it. That's what you need to be doing. Yeah, I've said a lot of times, if you take someone to that point, what do you have to do to document the skill in your chart? I mean, that's our requirement, right? That whatever this person is receiving, it required skill. Well, taking somebody to that point with exercise, that requires skill. You don't just get to phone that in and pass it off to anyone. It takes a bit of effort on your part to really kind of figure out, how do I get this particular person to work that hard? It's not an easy
You're not just like throwing the kitchen sink at them like, okay, I'm going to do 90 million different goofy exercises. It's like, this is very specific. And we always kind of get down these wormholes of what the physiology and the science shows that you're also adding on to that. But yeah, that's the key. And that still blows my mind. Like you said, people sometimes they're like, well, I'm kind of seeing results, kind of not. And I remember I talked with some guys at a pro team, and they weren't even progressing load. You know,
No.
it's like, it's not like you do nothing barely, and you, as long as you put a tourniquet on, you get, it's going to work. Or you put some goofy thing on, you do it for 40 minutes, and you're magically like, oh my God, my growth hormone went up. Everything's going to be healed.
Yeah. No, it's amazing. And we've seen, there are some that stick out in my mind where they've been pulled out of another facility and sent over, and they're like, oh yeah, I've been doing BFR. And I'm like, well, let's see how you've been doing BFR. And it's exactly what you're describing, right?
Yeah.
They were laying on the table doing straight leg raises, and they're 8 months out from an ACL reconstruction, right?
Yeah.
And like, it's not going to cut it. And I think, you have to, again, back to that clinical reasoning and how do you set up the program? These guys that are advanced to body weight exercises, and we're still using some BFR stuff, is so then maybe they do all their BFR at the end. I have some that we do BFR early on as more of a, like with quad sets or short arc quad or something like that. That's more of a, what I would call an activation, right? Mm-hmm. And then they go into their body weight stuff, and maybe they're running on the Alter G, and then we're doing what we would call like burnout stuff at the end. We're doing their more difficult stuff at the beginning. But that's sort of, again, like Kyle's talking about, that clinical skill. What's my decision making? How am I developing this program? Not just handing somebody a sheet of exercises and saying, yeah, here's your 3 sets of 10.
Taking a very injured limb to failure. I mean, that's a real talent and understanding. And you got to do that a new way on Wednesdays somehow. And then also, you get these people from other clinics. We see this with teams all the time that might have been using some, like, oh, they use this pump uppy thing. And then they're like, I've been doing BFR. And then you actually get them on, one of these microprocessed tourniquets, and they're like, holy hell, this is completely different. So when you actually get these occlusion pressures and then maintains it, it's a whole nother level.
Yeah, for sure.
Are you doing it on some of your elderly patients as well, or mostly the younger sportsmen?
We see, with the full gamut. We do have some older population. Trying to think, we've had some in their 80s, right, that have done it. I think we see a pretty significant number of upper extremity, like rotator cuff tendinopathy, like irreparable cuff stuff, or big cuff tears. So it's not just something we use for lower extremity. We definitely use it a lot for upper extremity. And we've seen really good results. I think if you look at the upper extremity sort of spectrum, you've got what I would call the non-invasive tendon debridement elbow stuff, similar to like my quad tendon guy I described, that have had some sort of biologic injection with a 10X procedure. Those do really, really well, those elbows. And so we've seen really good results on that. That's sort of a standard of care in our practice. And then the rotator cuff guys, they do well as well. I think that, anecdotally what we've done is there have been times where we maybe delayed using it on the operative arm and used it on the other arm while we were waiting. Right. And usually that instance that I found where we've delayed on the operative arm is I have someone who had a biceps tenodesis, and they're a little sensitive in the area where you would place the cuff. And I had, this lady who's maybe 100 pounds soaking wet, just really, really thin. And it's like, okay, we're gonna have to do this on the other arm for a while till we get a little further out. And, but they've done well. And the other thing that we've talked about with shoulder is during a lot of our rotator cuff patients, even non-op stuff, just regular impingement type thing, is they tend to be overactive in their biceps when they're doing their cuff exercises. And I know it's just what we've seen is they're getting the benefit of having the cuff on, but it seems like it's potentially inhibiting their bicep while they're doing their cuff exercises, because now all of a sudden, it's that they really feel their rotator cuff working, the biceps is inhibited, and so we get a little bit of that added benefit. But that's just,
no, I think that's
research based, but
no, that's super interesting. Jeremy Lineky at Ole Miss, he showed some work that the muscle directly under the cuff does get fatigued and kind of can get shut down a little bit quicker. So that's kind of fascinating to think about for those, because we all are like, God dang, I wish this guy would stop using his biceps. He's just pissing this thing off more, be it a slap lesion or a biceps tenodesis or tendinopathy. That if it makes the biceps not activate, fatigue a little bit, that's really cool to see it go that direction. And that's an interesting point on these older massives. I think Louis from El Paso was at that course with you at your place. I don't remember, it was a while back, but yeah, he had I think it was a 92-year-old massive cuff repair. Or not massive, non-operable, massive tear that he did it on. He's like, hey, how do you feel about me doing it on a 92-year-old? I was like, just tell me how it goes, man. I'm not going to say go for it. Like, oh. I deal with young service members. But he's got this amazing, like before and afters, the guy's arm elevated. And he's like, the docs think it's like voodoo or something. It was really weird. And it wasn't like this, like that day it elevated, but he did it for weeks. And that's what's interesting. These cuffs like that, the fatty infiltrate is the big problem. And so we haven't really had a solution for fatty infiltrate. Now, Amy Seitz over at Northwestern University, she put out a really interesting paper that showed that you don't actually get more fatty infiltrate, it looks like, over time. You actually atrophy the muscle, so the fatty infiltrate index gets higher. So you have a bunch of fat and you have a lot of muscle, but the muscle atrophies, so then you have more fat to muscle ratio. And so her study she's doing with BFR, with Illinois Bone and Joint, is just doing it on those kind of cuffs that are non-ops and going to see fatty infiltrate, which can set them up for success or even set them up for success if they have to have surgery.
For sure.
That's what I love, is those kind of like, now we're changing the way we're doing rehab. It's like, we're doing this to increase muscle volume, to reduce the fatty infiltrate index, to make you a better surgical outcome or whatever, which is not the way we've always kind of looked at rehab.
Definitely.
It's like a healing.
Yeah. And I think that, you see it with the quad and your cuff patients. And one of the things when I talk to my therapist is, I think a lot of times they forget that one of the best things you get out of this is the patient actually feels what it feels like to make that muscle work, right? Yeah. When you have somebody who's had quad inhibition and issues for years, and all of a sudden you put the tourniquet on them and you have that increased muscle fiber recruitment, all of a sudden they feel something that they've never felt before.
I know.
And I think, while it's, again, a little bit of a religious experience, however, it's welcomed. I think it's good for those guys to feel that.
Yeah. So it's like the light switch, it just goes on and they're like, wow, that's awesome to finally feel that. And that's, and that's the thing too, like seeing 50,000 or so BFR sessions. That's where we're getting now, is like, as a clinician, you're seeing more than we see as researchers. You do like maybe 20 studies with, 10 subjects. You're seeing way more. So you're going to pick up trends and pick up safety data.
Well, and it's interesting. I listened when you guys were talking about the risk of blood clot and things. And because initially, going back to that, oh my God, this is wacky. What are we doing? Yeah. And that your first inclination is blood clots and post-surgical and oh my God. And, we've not had an adverse event. Knock on wood.
Knock on wood. Yeah,
knock on wood. And we have had, there's one case that we had, and he was out there about his case, and he had a DVT after his surgery. So he was a professional bodybuilder, tore his bicep, rehabbing for the bicep, gets injured, tears his quad tendon and re-tears the bicep. And then because of a long extended flight after the injury of tearing his quad, post-operatively ends up with a DVT. It turned out it was pretty superficial, but that was like one of the big crises of that case, was like, oh my God, when are we going to be able to implement this? It was like everybody was just crushed because we wanted to be able to implement BFR. And it turned out that we did end up going back to use it. And we worked with the orthopedic surgeon, Dr. Katie's the PA for, and so what we were doing is working with the hematologist who was following the patient, saying, okay, we're He's on blood thinners, what have you. It turned out it was pretty superficial. And so once they were cleared there, and they were ultimately going to clear him to then have his bicep revised.
Yeah.
And so then once we hit that milestone, everybody was like, okay, we feel like we're in the clear, we'll monitor it. And we didn't have any problems.
He documented that. He has like an actual like movie on it, right?
Uh-huh.
I think I saw some video. He's at your facility doing blood flow restriction.
Yeah. Those cool. Guys they're tough to control. So that was, I was like, oh my God, if we can't use BFR, I have no idea what this guy's going to do on his own.
This guy's going to be doing quad sets in your clinic and squats at the gym, right?
Yeah, exactly.
Yeah. I know that was with a big pro athlete that had a pretty big back surgery. You know, they were like, one thing we just loved about it is he could do this and just do light squats. And we knew that would gas him enough that he wouldn't go off to the gym later because he felt like he was doing something.
Yeah, you better wear them out with you, or they're going to figure out some way to do it on their own, and it's probably not going to be PT approved.
Yeah.
And I think that gets buy-in too. You know, somebody comes in and they work really hard. They're like, wow, I really got my money's worth today. Like, I know I did something. Where too often I think people leave a clinic and they're kind of like, I don't know if that did anything or not.
Come back on Wednesday.
Yeah. Especially if that population that is used to having that switch turned on of like the endorphins of like really working out, and they're sort of like that high type A energy driven personality.
Are you using it as an aerobic component as well, like on the bike or treadmill? Good.
Yes. So we do the bike protocol. So we'll do that early on. I've had we'll do it with the elliptical trainer as well.
Yeah.
So, you know, for instance, like on maybe one of our, like a total program on a, you know, post-op ACL or hip or something like this is, you know, they'll do some body weight strength component. They'll do some BFR strength, some stuff, and then we'll do BFR with their cardio as well.
Good.
And so it's sort of like a all encompassing.
Yeah. Aerobic component as well as
exactly.
Yeah.
Exactly.
Awesome.
Yeah.
And what I love too, not only are you accomplished PT, running a business, very high-end clinic, but you're also finding time to start looking at doing some research with this as well, which a lot of people, I get this question all the time from clinicians, like, how can I start doing research? And I'm like, let's talk about your bandwidth right now, because I'm not sure if you have that available, but you've been able to do it. So you had a really cool paper come out with the Curlin Job guys. And I think we've talked about it on our podcast before, but I don't know if you want to discuss it, or I can kind of highlight the.
You can highlight it. It's probably fresher in your mind. I was, you know,
and holy we've talked about
2 years ago now.
Yeah, that's what's funny with research. We talked about it, like, hey, my new paper that I don't even remember I wrote 2 years ago. And by the way, I collected data 3 years ago.
Everybody wants to know all the details then, and you're like, man, that's down the road.
But yeah, basically that big question, and so much of the BFR research is like at a physiological lab. It's like, okay, they did leg extension, or they said bicep curls. And so I know we're always like, well, what about the rehab stuff that we really apply this with? Hip abduction, hip extension, straight leg raise, all that sort of stuff. So you took what we've got to point out, it was healthies. You know, this wasn't a population. And looked at doing the rehabby kind of the Jane Fonda exercises that bore the hell out of patients. But when you put a cuff on, it's completely different. And showed hypertrophy in the thigh and the lower leg in the BFR cohort, not in the control. 30% of a 1 rep max. Which you can estimate that in a healthy population much easier than the clinical population. We'll say that. But then also saw these strength changes in all those basic exercise movements. So hip extension got stronger, which was proximal. Hip abduction got stronger, which is proximal. Single leg heel raises got stronger. Quad got stronger. So and then you did the control, the groups also did the exercises on the opposite limb with or without a
Yes.
tourniquet on based on how they were randomized. And you saw a
Yep.
contralateral effect as well, or a crossover
Yes.
effect.
Yes.
So that's cool because you know what it did, and now you'll get to be cited by me in these studies. You know, we have a hip labral study going on right now at Rush in Chicago. We have a total hip study going on with Atos Ortho Park in Germany. And we can say, well, yeah, looking at least, you know, in a healthy model, it looks like these exercises can get the proximal hip musculature stronger. In other studies, you know, Dr. Abe's study showed that as well. So we've seen this is potential. So it's pretty cool to see that laid out. And now we get to apply it and say, okay, does this work in a clinical population? And then it's not published yet. I think you said it's about to come out, an upper extremity version of that.
Yeah. So basically same format, but for upper extremity, where, you know, they had a tourniquet on one arm. If they were in the tourniquet group, they did the exercises on both arms, and similar effects, good increase in girth and strength below and above the cuff,
Awesome.
as well as contralateral, if, you know, suggesting potential systemic effect. I think, you know, the things that I remember as we were doing this, I really was questioning in my mind. I thought, yeah, you know, this is going to be interesting. 2 days a week doing a tourniquet.
Yeah, and we'll point that out. That's the big question. Everyone's like, how, you know, clinically, I can't do this daily like the pro guys.
Exactly.
So twice a week. I love that you chose that because most of my clinical trials are 2 times a week.
Yeah. And it was twice a week and they didn't change. There was no other outside, you know, you're not doing additional stuff outside. This is your 2 days a week that you're doing this stuff with the BFR. And well, you know, you're supposed to just do the research, right?
Yeah.
And see what happens.
See what happens.
And so it was a pleasant surprise for sure.
And the upper extremity one is coming out in what journal? Do you remember?
Journal of Shoulder and Elbow.
Okay. So an orthopedic surgeon journal. Cool.
Yeah.
Cool. And that should be coming out soon. So we'll highlight that for sure in a podcast. And it sounds like it goes all right along with Brad Lambert's shoulder study, which found the same results. So you're not on an island. You know, another study that's going to be coming out basically did the same protocol and found the same results, which is really cool. And then again, here's how the Heather tentacles spread. You know, Eric Bowman, who was the primary surgeon that was the author on it, he was at Curl and Job. And then he went down to Vanderbilt, and I met him at a conference, and he said, you know, he started talking to me about, hey, I was on this paper, and now Vanderbilt is doing research with us since he's down there, and also our friend Dan Stinner. So I was able then to we recruited Vanderbilt onto our femur fracture trial, and Eric's got all the other plans. So keep doing it.
He was great. He was able to present too at AOSSM this last year as well, which was nice to see that be included in the presentation. So
he and I both presented at AOSSM. So to have two rehab studies presented at AOSSM is like a big win. You know, when the orthopedic surgeons just want to hear about the new arthritic thinker.
Yeah, I've been going for like the last 11 years, and there's not many rehab studies I've seen there.
No, it's awesome. Do you have any other studies that y'all are engaging in? Or I know Orr was talking about some orthobiologic stuff. And he was always talking about all these residents. He wanted them to do studies.
Yeah, there was one, and I haven't looked at we haven't gotten the results back together yet, but we did do one that was some BFR with core training and looking at if there's a transfer effect and what it would be on like core strength. That's one that we haven't sifted through all the data yet. The other one is we're looking at maybe doing a retrospective review on a lot of these Achilles tendon cases and comparing them to whether we use BFR or not, because we, you know, with the number of cases that we've seen in our facility compared to outside of our facility, is there something that we can take a look at there?
For Achilles repairs?
That's all. Yeah, for Achilles repairs. And I think that's always a challenge.
So what have y'all seen just anecdotally, Heather, with your Achilles repairs? It's a question we get a lot. And I mean, I have my own thoughts, but what have you guys really been seeing?
it's like, to me, on an Achilles repair, it's a godsend. It really is. I mean, when you're looking at, if you have the ability to get these guys early on and you're doing like a self-swelling protocol and you're decreasing the atrophy. I mean, when I went back and I looked at that one, I mean, we were at 15 weeks post Achilles repair. I've got a guy whose calf girth is 92% of what the other side was. And that's like unheard of, right? If you've been doing this for a while, it's like, you know, hallelujah when you can get them to do a single leg heel raise at any certain time. So, and so I think on Achilles, it's definitely been well received, and we're seeing good strength gains and what have you. I think what we've used, we're fortunate we have an Ultra G. And so one of the things that we would do to sort of quantify how much, when they can do a heel raise, is we put them in the Ultra G and have them just stand in there and put the percentage of body weight that they're at when they can do a full heel raise, so that we can sort of objectify that. I think that's what, when you start looking at the retrospective stuff on Achilles and rehab, I mean, notoriously, PTs, I'll be the first one to say my documentation sucks.
But if you're measuring things like that are reproducible, you know, you have something to kind of anchor, you know, to be able to tell and scale that you can kind of gradually progress. Now you can see, hey, this person is actually doing something. And I think that's a piece that PTs and probably athletic trainers as well miss a lot, is they don't have certain things that they're looking at and ways to regress and progress them to really be able to tell, all right, this person is getting better. I mean, it's nice to have a Biodex and various other things where you can really truly measure, but there's plenty of other things that you can use. Like, I mean, an Ultra G, you can go in 1% increments of body weight. That's awesome.
No, I love that. It's almost like we should put a video of how to do that. You know, I was part of a fasciotomy trial out of Mayo years ago, and just trying to validate a good measure of calf strength was next. There was zero validation out there. The Biodex very sloppy, big coefficients of errors with it, and you know, unless you just use a really well-powered biomechanical lab, it's very, very hard clinically to measure calf strength. So the Biodex model is great. I mean, the Ultra G model is great. You know, if you can control their lean forward, or you know, they're not using their hands to push off or whatever. So, and you have that data that you can retrospectively gather on those.
So, and I think the challenge we have is probably not everyone has been consistently documenting. And so we're trying to go through now and say, okay, here's our, like, so that we can continue to look at this kind of stuff in the future, is here's what our standard basic measurements we want to be able to get on everyone moving forward, so that you can gather that stuff. You know, and kind of talking more about the Achilles, one of the big questions that came up in discussions with the surgeon is, when would you implement this? And are there issues with the scars and things like that? And I think we've not had any adverse effects with incisions. And I think, you know, we've had some that start pretty aggressively, depending on the way they look, that might be 3-4 days afterwards. However, maybe we adjust the pressure, but that's where sort of that clinical judgment, and having done this for a while, you know, the Achilles, a lot of times they are in one particular surgeon that we work with a lot. He's got them hunkered down in a cast that nobody's getting to that ankle for probably 10 to 12, maybe 14 days. And so just by that alone, you're probably not starting until 14 days after anyways. And at that point, I never usually have many concerns on the incision.
Yeah, I think that's a key point. You know, we did a lot with Achilles, and we put a retrospective paper out. It was like 2 or 3 cases, but and they were more chronic. But we really started to see is if we could tip that dial back to more acutely within the first 2 weeks, get them started, because it really seemed like if we waited past that 6-week protected phase, it was hard to get it back. And we're seeing these like kind of terrible adaptive changes that happen to the muscle when you're in disuse, and maybe that played a role in it. So I think the success with Achilles is probably going to be the acuity of getting it on.
For sure.
We do it so much, you know, I can't tell you how many workers' comp professional claims we've processed for Achilles. the teams have really kind of bought in. So let's get it started right after surgery. So we'll see. Mark Dracos up at HSS, he's their foot and ankle guy. He's got an Achilles trial going on right now. So hopefully he'll have some data for us soon so we can kind of see where it teases out. So
Great.
cool.
Great.
Man, Heather, any other?
I would say, one other thing I think that I hear a lot in the private practice section, and this sort of goes back to what type of device that you decide to use. And I think, for us, people will say, oh, well, the cost. And I think you have to, the way that I approached it, and everybody has their own way of how they want to do this. For me, it was sort of like the decision that you go through when you decide to have an AlterG in your facility, right? It's an investment. Do you think you're going to have a cash-based product line around this? And there was never in my mind, I thought, I don't have time for that. Maybe that's a wrong decision, but that was sort of my approach, was that I'm doing this and I'm bringing this into my facility because I feel like my patients, the outcomes with my patients are going to be better. And that my patients getting better and having a better outcome is worth more in the long run than trying to screw around and say, oh, I'm just going to use it for this special population that's willing to pay for it and what have you. And it's a decision everybody has to make. But I think for me, that's how I've implemented it in my facility. And I'm not all cash based. I take insurance. And not all insurance, but I take some insurance that doesn't pay very much money, right? But that's my decision, and there's a way to get it done, in my opinion. And I think for me, it was never worth sacrificing a product that wasn't necessarily going to work, right? Or that I couldn't control the variables. It wasn't worth the risk, right? If you're going to do this, then you need to do it, and you figure it out, financially, and how you run your facility. So, but yeah, we've never set it up as a cash-based product line. Could you? Yeah. But I think I look at it more as this is what we do, a standard of care and a way that we deliver. And I think, we've got a busy facility and a lot of therapists, and we have 6 units in the facility. And I think
you just made a lot of people very jealous by saying that.
But we worked our way up to that, and I think, we've been fortunate, and I think it's possible to do it, but you have to you've got to figure it out. Each business owner has to figure it out, make the decisions, but it's possible to do it.
I think the tough thing for PT businesses too is yearly, your cost on equipment is pretty small, right? Yep. I mean, you're not spending a ton of money on exercise equipment each year. You have some upfront costs to get going, but then year over year, that kind of levels out, and you're not really spending a ton. I mean, maybe run some TheraBand and replacing some cuff weights here and there. But I mean, good grief, the practice I was in, we had the same cuff weights for the entire 15 years I was there. I was there, at some point you replace them with those goofy ones with the buckles. I hate that person that developed those cuff weights with the buckles, and you got to wind it back and forth. I don't know who that person was, but they were clearly
Velcro. Leave it with the Velcro, with the peat green and the rust and the old school 70s colors. Just
seriously,
don't change the colors.
You gotta have the baby poop brown 3-pound cuff weight. These are requirements of any quality rehab facility. You have to have those things.
Yeah. And I think it's I just know, having been in the rehab world, sort of the way that, the more expensive pieces of equipment, their usual go-to how to sell it is like, well, you can do this as cash-based and what have you. And it's like, listen, there's some people that are really good at that game. I'm sticking to my lane and what I'm good at, which is orthopedics and post-surgical stuff and rehab, and we'll build the insurance. I have some that pay cash, and I'm not interested in trying to justify purchasing it by doing that. We're going to do good care.
Good outcomes.
Exactly.
Yeah. And obviously now you've got the biggest orthopedic group in LA that wants to just continue feeding you because of your outcomes, not just from buckle restriction, but from everything else. But I think you differentiated yourself early on in LA with blood flow restriction as kind of one of the power centers. And I always, when these teams reach out, like, who do you have in LA? I'm like, all right, here's my list.
It's a no-brainer.
You guys have been doing it. They probably know it better than I do now. So cool. Yeah. Well, thanks, Heather. That was awesome.
You're welcome.
I miss you. I was going to see you guys, a week ago, Kyle, I think. I was supposed to be out at USC. So,
oh, man.
We got shut down.
We'll reschedule and we'll all go hang out and do a happy hour. These virtual happy hours are bullshit.
It doesn't quite cut it.
Translate. I know.
Not the same.
Cool. Well, thanks, Heather. Stay safe.
All right, great seeing you guys.
Hopefully your practice, we didn't really go into it, but the COVID thing, I know it slowed you down a lot. You're still doing some, but not as much. And hopefully we all get past this fast. And
we'll be all right on the other side.
Yep. Cool. Well, have a fun Friday night. We'll talk soon.
All right. Sounds good. Thanks, guys.
Thanks, Heather.
Bye.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.